Consortium, if you've never participated with us, we're a group of, we have membership from 9 organizations: Torrance Memorial Medical Center, Torrance Memorial Physician Network, Healthcare Partners, California Hematology Oncology Medical Group, the Cancer Support Community, the American Cancer Society, Beach Cities Health District, Kaiser Permanente South Bay, and Harbor UCLA. And we get together every month and look at the feedback that we get from everybody's evaluations, and we look at the literature and we see what's in the literature, what's being discussed, what are the needs for cancer survivors, and that's really how we come to provide these programs, which we do in May and August of every year. A few more thanks to the consortium members who work diligently to do this, also to the Cancer Resource Center team who helped set everything up today. I'm very appreciative of them. Lilly Oncology, Christine in the back, who always brings water, and the art display, which gives us something, yay! Which gives us something a little different. And Katie Adams, oh, there she is by the food, because she brought the food tonight. So yay, thank you, Katie, from Genentech. And did I say, Christine, you were from Lilly Oncology? I did, okay, good, I got that. There are also information and resource tables over on this side of the room to your right. And this time, Kaiser Permanente, thank you, ladies, brought adult coloring books, because you can never have too much. And they're very pretty, and some cookbooks. So I'm pleased to introduce tonight's program, talk a little bit about living and thriving with metastatic cancer. The goal of our program tonight is to provide information on how living with metastatic cancer has changed, the role of supportive care, and strategies survivors can use to enhance their overall well-being. So it's a really nice, comprehensive look at living and thriving with metastatic disease. We're really pleased to have experts in the field. We have 4 great speakers tonight. First one is Judy Schneider, who is going to share her experience with living with metastatic cancer. Dr. Thomas Lowe, a medical oncologist, who will provide us with the why and how cancer therapy has changed through the years, rendering metastatic disease more of a chronic illness in many cancers and new therapeutic modalities. Dr. Eve Makoff is a palliative care specialist who's going to broaden our understanding of palliative care for all of those diagnosed with cancer, including cancer survivors, and discuss how palliative care interventions positively impact quality of life. And then we will have Nancy Lomibao, yay Nancy, from the Cancer Support Community, who is a licensed marriage and family therapist, address the social and emotional aspects of living with metastatic disease, such as managing expectations and fears, communicating with family and loved ones, and providing information on coping strategies. So like I said, a very comprehensive look in a very short period of time tonight. So we hope you will take advantage, ask questions. We'll have questions after each speaker. Halfway through, we're going to have a stretch break, because we've gotten feedback from the many programs we've done that people like to kind of move some body parts halfway through. Yeah, stand up, sit down, breathe, that kind of stuff. Couple of things. If you didn't sign in, please do so on your way out, or if you're wandering to the bathroom, which is out the back door to the right, please make sure you sign in. And I just want to go over what's at your seat. Everybody has an evaluation form. That's the beige, I don't know what to call it. Anybody know? Beige? The one that's not white. We'll just go with that. That's the evaluation form that we really would love you to make sure everybody fills out. It is probably the most important tool for us, because we use that information to determine what's next. What do people want to hear about? What do people want to learn? And that's what we turn around into almost all of our programs. We do take stuff from the community, what's out in the literature, what's new, but we really do rely on your feedback. Not only to tell us how we did, but to tell us what you want to learn. So there's going to be red containers in the back on your way out, and smiling people who are just sitting there waiting for your evaluation form. Other things that are at your table, there's something to take notes on, and then two pieces of information that we got from the American Cancer Society and the American Society of Clinical Oncology on living with metastatic disease, and information about the support program at cancer support community that's specific for people living with metastatic disease. We don't have an exact date, but somewhere in the middle of August is our next program, and I'm very excited to say the title is Recognizing and Managing Cancer PTSD. That's a topic that's come up. We've always heard, the feedback we've gotten over the years, how do you cope? What do you do? How do you live with this short-term, long-term? So we're really excited about that. Using that seeing that combination of that newer terminology of PTSD used in combination with a cancer diagnosis. Because if you've been through it, you know, that's not a foreign relationship. That's actually pretty consistent. This program is being recorded. Hi, Mitchell. As have all of our previous programs, and they're available on the website, which is flashing during this. Housekeeping, I mentioned the bathrooms are in the back, out the door to the right, both the men's and the ladies' room, and please check to see if your cell phones are off. Because people who are seeing this on the internet are going to know that you got a call. And I'm not sure that's the best thing. That's not how we want to present ourselves. So again, thanking Lilly Oncology for bringing the art and bringing the water, thanking Katie Adams and Genentech for the great food, and all the consortium members and volunteers that participated. Last note of business is we will be taking questions. Did I say that? Maybe I did already. Question and answers after each speaker. So there are two people that will be holding microphones and doing their best. Phil Donahue, I'm dating myself, I know that, going through the audience after each one. So just raise your hand and someone will show up. So with that, I think I've done all the housekeeping things. Did I miss anything? Oh, only one advertisement. For those of you that come to Torrance Memorial routinely, our National Cancer Survivors Day celebration is June 5th. So if you go to our website, all the information for registration for that event is there. And we'd love to have you if you've been. If you've not, you're welcome to come. It's open to all cancer survivors and their family members. So it's a lovely dinner. We have a terrific speaker. His name is Nakul Dev Mahajan, and he is the Bollywood choreographer that has choreographed. I'm a nerd. So you think you can dance? I know, he's very cool. And he's a cancer survivor, and he's got a wonderful story to tell. So with that, I'd like to bring up our first speaker, Judy Schneider.
Once upon a time, I was a very active 62-year-old woman, and then bam, my life changed with one phone call. My name is Judy Schneider, and I'm very honored that my oncologist, Dr. Lowe, invited me to speak here tonight. I am living with metastatic ovarian cancer, but thankfully, I am doing well. In January of 2017, I went in for my annual gynecological checkup and told my doctor I was having a little bleeding and bloating. My gynecologist did an in-office biopsy, and a week later called me to tell me I had endometrial cancer. How could this be? She recommended I see Dr. Reimel, an oncologist at Cedars-Sinai, and got me an appointment the following morning. Dr. Reimel told me I needed to have a laparoscopic hysterectomy, and more than likely, I would be able to go home the very same day. In 85% of the cases, this is all that is needed to remove endometrial cancer. No chemo, no radiation, just laparoscopic hysterectomy, and I'd be good to go. I signed on that dotted line. We scheduled my surgery for 3 weeks later. I went into my surgery feeling very positive and thinking it was just a little bump in the road and I'd be fine. My 90-minute surgery turned into a 7-hour surgery, and I was in the hospital for a week. When I got home, I got a call from Dr. Reimel telling me that I had stage 4 uterine sarcoma carcinoma, also known as USC. She told me that it was a rare form of cancer and the outlook was very bleak. My husband, Dean, my most supportive partner in the world, listened to my phone call with me, and we sat and we cried and had a big pity party. The next morning I woke up and said, okay, it's time to put on my boxing gloves and figure out how to get through this nightmare. One of my biggest fears about having chemo was losing my long, thick hair, so I tried doing the cool cap, whereby you wear a frozen cap throughout your chemo treatments and a few hours afterwards in order to freeze your hair follicles so your hair does not fall out. Unfortunately, after a couple of months, my hair fell out anyways. I do not recommend going through this route because it was time-consuming, costly, and it doesn't always work. The drive to Cedars-Sinai from Manhattan Beach was brutal, and after one treatment, I decided to look for an oncologist closer to home, somewhere in the South Bay. I was very lucky to get an appointment with Dr. Lowe, who came highly recommended by my close friend, who is one of his patients. I had an instant connection with Dr. Lowe, who I trust with my life, literally. He is the best. Dean and I love Dr. Lowe and consider him a friend as well as my doctor. I also love the girls in the front desk at Cancer Care. They always make me feel warm and welcome. Wait 1 second. Dr. Lowe looked over my records and said, something in your diagnosis just doesn't add up. He had me take a BRCA test, a genetic test, which I'd never taken before because to my knowledge, no one in my family ever had the BRCA gene. Well, sure enough, I'm BRCA2 positive. From this revelation, my diagnosis was reevaluated and I learned that I did not have stage 4 uterine cancer, but rather I have ovarian cancer 3C. Dr. Lowe said this is a better diagnosis for me, but unfortunately, I needed to have my family tested. Since my 92-year-old active and vibrant dad is still around, and he tested negative for the BRCA gene, that meant I inherited the gene from my late mom. The odds are 50-50 that you'll get the BRCA gene if one of your parents have it. But all 7 of my family members who were tested turned out to be positive for the BRCA gene. So much for 50-50. I continued my chemo treatments with Dr. Lowe's team at Cancer Care, and when I was done, I had a PET scan and I was told my cancer was gone. Yay. I did the whole wig and baseball cap thing for about 6 months. One of the toughest parts of my chemo was looking in the mirror and seeing my own reflection. I'd think to myself, who is this person in the mirror? I was bloated from the steroids, my eyes were sunk in with big dark circles, my hair was all but gone, I had no eyebrows or eyelashes, and my skin was a pasty shade of pale. I feared I would never look like my old self again. I had to adjust to my new normal. It would have been easy to blame my aches and pains on my illness and just sit around doing nothing. I am a very lucky girl because I have an amazing support network. My wonderful husband, Dean, has been there for me 100%, and I credit him for where I am today. He has a very positive attitude, and he pushes me to get out and exercise, eat regular meals, and be a part of the real world. He, my kids, and my granddaughters are my best medicine. When I'm with them, all the bad stuff goes away. A cute story about my granddaughter, Sydney. When she was 5 years old, I went to pick her up at her preschool, and I was wearing my wig. Sydney put her hand up to her mouth and whispered loudly to her teacher, "My Nana is wearing a wig, and she doesn't have any hair underneath it." What a little yenta. But I didn't care, and her teacher and I had a good chuckle. I reassured my granddaughters that I was bald now, but my hair would grow back soon. When my hair started growing back in, I'd say to both Sydney and her 2-year-old sister at the time, Hazel, wig, baseball cap, or nothing. They became my new fashion experts. I'm still achy and tired, and I have neuropathy in my feet, but I don't want to seem weak or complain, so I push myself and collapse on the sofa after everyone's gone. My incredible kids call me and check up on me daily, and I know they would do anything for me. I'm also very fortunate to have an extremely loving family and many good friends who have stuck by my side through this whole ordeal and offered me unconditional love and support. When we have plans to go out, if I'm tired and would rather stay plopped on the sofa in front of the TV, I force myself to go. I derive strength and positive energy when I'm with them, and I tell them regularly how much I love and appreciate their being there for me. It makes me feel good to express my gratitude. Unfortunately, 9 months after my treatment ended, I got hit by the unlucky stick and my cancer came back. After I finished my first go-round with chemo, I swore I'd never go through chemo again. But when Dr. Lowe said I'd need to do more chemo, surprisingly to me, my response was, how soon can I start? I guess I wasn't ready to give up. I began my next treatments right away. Throughout both my chemo sessions, I did not get a port or a PICC line. It was always a challenge to see how many times I'd get poked before they'd find a good vein. It wasn't fun. I swear the chemo nurses at Cancer Care drew straws to see who would get the short straw and would get me as their patient. When my chemo treatments were over, I was put on a PARP inhibitor called Lynparza, which is in pill form and is specifically targeted for women who have gone through chemo more than once for recurring breast or ovarian cancer. Lynparza works best on women who have the BRCA gene. It is relatively a new drug that was approved by the FDA in January 2018. It's all about timing. I'm very happy to say that my CA-125 cancer marker is down to 11.4. The normal range is 0 to 35. By comparison, right after my 2017 surgery, my CA-125 was 1,330. Luck has been on my side so far. So how do I cope with metastatic cancer? I have a few things that work well for me. My husband, Dean, and I both mentally put all of our cares and woes in a box, and we put the box up on the top shelf in my closet. We try not to open the box unless we have to. I love the quote, "Don't worry, it may not ever happen. And if it does, I'll deal with it then." We go on with our daily lives, stay busy, and enjoy every day. I go once a week to my trainer, Angelo Messino, and after every workout, I thank him for keeping me strong. Angelo tailors my workouts for strength and endurance and balance. I notice that I am clumsier than I used to be, so the balance work is very important. I love the feeling of accomplishment I get when I'm done with my workouts. I feel like I can conquer the world. I also take long weekly walks on the Strand with my girlfriend, and we try and solve the world's problems as we walk beside the beautiful Pacific Ocean. Having company while exercising doesn't make it feel like a chore. It feels fun. Afterwards, I go home and poop out. I take both Cymbalta and Trazodone. Cymbalta was given to me for my sore muscles and joints, but it's also an antidepressant. I don't think it's doing much for my muscles and joints, but thankfully, I'm not depressed. Trazodone was given to me to help with sleeping, hot flashes, and anxiety. So I sleep well, I don't get too many hot flashes, and I'm double covered for depression and anxiety. I have no plans to ever go off these meds. Like the old saying goes, if it ain't broken, don't fix it. Additionally, I take CBD and THC cannabis oil. They help me with my nausea, and I hope they will keep my cancer away too. My niece Dana works at Canna Kids, and they make flavored cannabis oil. Personally, I'm a big fan of the bubblegum flavor. Having cancer has given me a new perspective on life. I love and appreciate everyone around me like never before. I find that I'm very happy and content with the simple things. I don't need fancy restaurants or exotic vacations. It's all about the company I'm keeping and staying busy doing the things I love. Having said all this, it's important to let all your feelings out now and then. I have a dear friend, Karen, who is also going through ovarian cancer, just like me. She and I have become very close because we can bitch and moan to each other, and we both truly get it. No one wants to hear about every ache and pain, but with my friend Karen, we love to get down and dirty talking about all the stuff we're going through. It feels wonderful and cleansing to let it all out and share with someone who's in the same boat. Karen is also about the funniest person I know, and we crack each other up. Laughter is great medicine for what ails you. Getting ovarian cancer and finding out that I had the BRCA gene has been difficult. Learning that I passed the BRCA gene on to my kids has been doubly difficult. I know it's not my fault, but I feel tremendous guilt about giving it to my son and daughter, and possibly to my granddaughters, who probably won't be tested until they're in their 20s. However, knowledge is power, and I feel like I am the messenger, warning my family about this hereditary gene so they can be ultra diligent and do whatever is necessary so they don't end up in the boat like me with cancer. Overall, I try and look on the bright side of life, appreciate the present, and choose happiness over all other options. Be well, everyone, and thank you for listening to my story. So I had a few pictures sent over. This was me attempting to do the cool cap. If you've never seen it, that's what it looks like. And the gal next to me was the one that helped with keeping it the perfect temperature. But it, like I said, didn't work for me. Do I have a clicker? Oh. That's me. Just about done with my first go-round with chemo. You can see how lovely I was. It was pretty frightening to me. That was me, maybe a month later, wearing my baseball cap with hair, putting on some makeup, and pushing forward, because that's what you do. We took a vacation, and though I was wearing my wig and hat on and off, I actually took it off, and that's what I looked like. This is my little granddaughter, Sydney, and like I say, laughter is good medicine, so she and her sister in the next picture probably. No, that's my daughter. She's wearing my wig. We all had fun with it. And I think that was it, right?
That was it.
Yeah. Anyways, I sent more pictures over, but they didn't get there. So thank you, everyone.
Thank you, Judy. That's quite a story. Not once, but twice. It's a lot. And you are an example of living and thriving. So thank you very much for sharing. With that, I'd like to introduce Dr. Thomas Lowe. He graduated from UCLA David Geffen School of Medicine and completed his internal medicine residency at UCLA and his fellowship in hematology oncology at the City of Hope. He's achieved multiple accolades, including Phi Beta Kappa and Alpha Omega Alpha honor societies. He is double board certified in hematology and oncology and is an investigator in clinical trials, including collaborative trials with UCLA and Cedars-Sinai. His special areas of interest include breast, ovarian, lung, colon, and prostate cancers. How do you choose? Dr. Lowe has served as the youngest physician to have been elected as chief of staff in our local South Bay hospitals. He attributes his passion for caring for oncology patients to his wife, a survivor of childhood acute lymphoblastic leukemia, who he met as a teenager. Dr. Lowe.
Thanks, everybody. How do you follow up Judy? Good gosh. Well, this is interesting. I graduated medical school in 2002. If you would have thrown up this slide in 2002, I'm not sure how many people would have believed the topic or would have come to listen about this topic. How times have changed in the last 17 years. One of my favorite quotes from Albert Einstein, learn from yesterday, live for today, hope for tomorrow. The important thing is not to stop questioning, and as we did with Judy. The other quote I like, I don't know who made it up, is you hope for the best, you prepare for the worst. And when I graduated medical school many years ago, with metastatic cancer, we had some hope, but a lot more preparing than hope. Cancer was historically thought of as a short death sentence. Now the majority of patients are cured of their disease. Those who are not, often, not always, but often have hope of making cancer a chronic disease and still being able to enjoy good quality of life. So briefly on how cancer starts, all cancer is genetic. That does not mean inherited, but all cancer is genetic due to mutations that can happen spontaneously or because of our environment or what have you. And what happens is that cancer cells are like our normal cells, except they become more powerful, they become mutated, they grow faster and adapt better than our normal cells. If anybody wants to know about the biography and the history of cancer, I highly recommend this book, bestseller from about 2011 or so, given to me by one of my patients. So new cancers in the US in 2019, we will have close to 1 million new cancers every year, both in men and women, with the leading being breast and prostate, followed by lung. 5-year survivals, look at the 1970s to 2014. Our cure rates, or relative survival rates for 5 years, mostly cures, have gone from 49% to 69%. If you looked at some of the select cancers there, breast is up to 91. Cancers such as the prostate have gone from 68 to 99% 5-year survivals. So per the American Cancer Society, about 38.4% of men and women will be diagnosed with cancer at some point in their life. Certainly it gets more common as we get older. So more than 1 out of 3 of us will get cancer, and this excludes non-melanoma skin cancer. So this excludes squamous carcinomas, this excludes basal cell carcinomas. And as of January of 2019, there are about almost 17 million cancer survivors in the United States, representing 1 out of every 20 people, 5% of the population. And this is expected to increase to 20 million by 2026. So in the last 25 years, cancer death rate has dropped 27%. This is attributed to decreasing smoking for sure, and also in earlier detection and also better treatments. So how did we get here over the last multiple decades? So surgery has been the mainstay of therapy for centuries. Surgery, however, is only rarely an option in metastasis. The vast majority of people, unfortunately, who have spread of their cancer are not eligible for surgery, with select exceptions. Most of our patients, the options are the following: chemotherapy, which is chemical warfare, endocrine therapy, which is anti-hormonal therapy, targeted therapies, and immunotherapies. Those 4 have revolutionized cancer care in the last 20 years. So history of chemotherapy. Where did chemotherapy come from? So it was found kind of by accident. So back in World War II, Germany bombed the Italian port of Bari, where we had one of our ships, the US ship John Harvey, was sunk with a secret cargo, which was 100 tons of mustard gas. So it was our chemical bombs, and many of the people who survived that but were exposed to that sinking, the Navy, those individuals were found to have low white blood cell counts. They were found to have shrunken little lymph nodes, and very astute doctors wondered whether that kind of treatment, if you want to so call it, that kind of chemical treatment might be used to treat things like leukemia, cancer of the white blood cells. So after that, clinical trials were developed mainly on the East Coast towards Harvard, where the first successes were seen in childhood acute leukemia. Okay, initially with initial treatments with single agents, and we would see remissions in children for many years, and later multi-agent chemotherapy, which now cures the majority of acute leukemia patients. But chemotherapy can be toxic. Cytotoxic chemotherapy causes a lot of side effects. The side effects tend to be greatest in rapidly dividing cells, hence why we have bone marrow toxicity, impaired wound healing, hair follicle damage, typically in the hair, not so much usually in the rest of the body, except for Judy with her eyelashes and all that. The gut, because the gut is constantly dividing, can affect growth in children, and it can affect fertility as well. So despite the advances of other treatments, chemotherapy will always have a role in treatment of metastatic cancer. The modern era of chemotherapy is often less toxic, more convenient, and we have better supportive care options. Examples, for lymphoma and leukemia, we have bendamustine. Doesn't cause any hair loss, typically works better than even our old multi-agent chemotherapies. For colorectal cancer and breast cancer, there's an oral chemotherapy called Xeloda, very convenient for people to take, and the list goes on and on. But what's really exciting now is to be able to move away from chemotherapy. And we have had endocrine therapy for many years. So the two diseases that we think about endocrine therapy most, okay, is breast cancer and prostate cancer. So the idea of it in breast cancer is if a breast cancer feeds off of estrogen, which is most postmenopausal women with breast cancer, we can take away its food. And its food is estrogen. And just giving an anti-hormonal pill, an anti-estrogen pill, which either lowers or blocks estrogen, in the curative setting, we improve cure rates by 50%, okay? Even if cancer has spread, or cancer came back and spread in hormone-positive breast cancer, taking an anti-hormonal pill, it's not uncommon to see women 10 or 20 years plus out of their diagnosis of metastatic disease, still taking their anti-hormonal therapies. Similarly, with prostate cancer, the reason why 99% of men with prostate cancer are still alive at 5 years, it doesn't mean all those men are cured, but even if they're not cured, many of them can take anti-testosterone treatments. So the history of endocrine therapy actually dates back to the 1800s. Okay, a Scottish doctor named Dr. Beatson first reported cases of premenopausal women who had fungating breast cancer, where he removed their ovaries surgically, hence lowering estrogen, and he documented regression of their breast cancer. He didn't know what it was. Back then we didn't know about estrogen, but that was the first link between ovaries and breasts. Tamoxifen was the estrogen blocker, was first approved in 1977. Then came Arimidex, the aromatase inhibitor, approved in 1995, and then Faslodex approved in 2002. So as prostate cancer, we first started learning about testosterone and ways to treat it in the 1940s. The chemical that now we use, such as Lupron now, was developed in the 1960s and 80s. And then similar to tamoxifen, flutamide was developed in the 1980s and 1989, and now we have other agents approved in 2011 and 2012. So the majority of women with hormone-positive breast cancer and men with prostate cancer, they go many years on anti-hormonal therapy before even considering chemotherapy. What about targeted therapies? Okay, so if we use the analogy that chemotherapy is chemical warfare, hormone therapy is starving your enemy of its food, targeted therapies is like having a sniper shooting right at the cancer, okay? So this list of medications I'm going to tell you is a very select list. I could go on for hours on all the different targeted therapies in different kind of cancers. But one of the first targeted therapies developed was a VEGF inhibitor called Avastin. This is a blood vessel blocker. The idea being that cancer needs blood vessels to grow and to feed off of the blood. And in colorectal cancer, Avastin was approved, I believe, around 2006 or so. And even very early on with this targeted therapy, we saw significant increases in survival. And breast cancer, this was the biggest targeted therapy to date, the advent of Herceptin. Herceptin was first developed at UCLA. UCLA first thought in the 1990s, they said, well, we know that there's a protein on the surface of cells called HER2. And for women who have that, it's a horrible diagnosis back then. It essentially doubled or tripled someone's risk of their cancer coming back. So they said, well, why don't we develop an antibody against that? And everybody thought they were crazy, okay? Nobody thought this would work. And lo and behold, when Herceptin first came out and was used in clinical trials, it is now better to have HER2 positive disease than HER2 negative. Why? Because targeted therapies work so well, okay? Where the cancers just melt away. And now we have multiple agents that attack this little protein on the surface of these cells. EGFR inhibitors, these are antibodies against the skin, actually, called epidermal growth factor receptors, which is used in head and neck cancer, as well as colorectal cancer, and PARP inhibitors. Okay, so this is Judy. Okay, so this is ingenious. So when the scientists behind who come up with these are pretty remarkable. So the idea in the BRCA mutation is that in certain tissues where BRCA, the gene, is expressed, mainly in the breasts and ovaries, that BRCA is needed to help repair the DNA. And we're always going to make mistakes in dividing cells and copying our DNA. And these are one of the many DNA repair enzymes. So when someone has a BRCA mutation, they don't have the ability to repair some of the mistakes that your own body makes with replicating ovarian and breast tissue. So a PARP inhibitor is like the idea being these cells are mutated to the point where they're very erratic, they're prone to mutations, they can't repair the mutations. It's like standing up on one leg and trying not to fall down, but they're going to keep on falling down and mutating. These scientists decided, well, if they're already not very steady, why don't we just kick out the other leg? Okay, this is actually inhibiting their ability to have DNA repair, which they already aren't very good at. But the idea being you kick out two of their legs and then they will die. They won't get up, they will die. And if you look at these curves, I know a lot of people aren't used to looking at these curves, but this is a survival curve. So these are patients with recurrent metastatic ovarian cancer who, after their second chemotherapy, were placed on this oral targeted PARP inhibitor, okay? And this is, the bottom line is going out about 54 months, okay? 54 months, 4.5 years, okay? And look at the placebo. Patients have their cancer come back, okay? Look at the top line. Those are people who are taking Lynparza. As you can see, going out 4.5 years, or almost 4.5 years, more than 50% of people are still taking their Lynparza, okay? And it's plateauing, which means it looks like some people, it just keeps on working and working and working, okay? This is unbelievable what it used to be about 5 or 10 years ago. So another example, if you see any commercials nowadays advertising cancer agents, it's usually for lung cancer. One of the agents that we have now for lung cancer is an oral targeted agent called Tagrisso. If someone has the right mutation called an EGFR mutation, especially in Asian never smoking patients, this is the survival curve for people on EGFR inhibitors. Okay, even the old EGFR inhibitors. Lung cancer, the average survival used to be 6 to 12 months. This survival curve goes out 2.5 years, and about 80% of people are still alive taking their Tagrisso, again, an oral pill. So the evolution of our treatment arsenal then moved on to immunotherapies. And the immunotherapies is the idea if your immune system is thought of the police force of the body, this is empowering the police force. So checkpoint immunotherapies are the idea is if you are a bad guy, okay, and you're coming up to a checkpoint where the police officer is supposed to check you and say, are you a good guy or a bad guy? And if you're a bad guy, I'm going to kill you. Or maybe that's a little dramatic, but that's how it works in the immune system. So there's something called PD-L1. PD-L1 is basically a badge that says, I'm a good guy. Even if you're a bad guy, you have a badge that says, let me go. So certain cancers, especially lung cancer, will have this badge. And what happens is that, I'm sorry, the slide is supposed to have some other guy pop up. But if you have an antibody that we give intravenously against that badge, what happens is your immune system can then see the cancer as being cancer, and your own immune system will then kill the cancer. So we give medicine now which doesn't even directly attack the cancer. It actually just empowers the immune system to see the cancer, and that's what immunotherapy is. So immunotherapy, actually, the thought of it has been around for decades. It's only been used historically decades ago for kidney cancer and for melanoma, okay? And historically, it was tried over and over again in different cancers, and it just never worked until the 2010s. And 2010s was when these PD-L1 inhibitors and another called CTLA-4 inhibitors got approved. And if everybody remembers the story of President Carter, metastatic melanoma to the brain mets, I think at age 91 or 92, he underwent immunotherapy. He's been in remission ever since. He's probably cured of his disease. So this is now, if you look at the dates, from 2014 to 2018, these are all the approvals for immunotherapy for different cancers, okay? I mean, it's ridiculous. About every month we're giving a new approval for immunotherapy because it seems, remember, when we give immunotherapy, it's not cancer specific, meaning we're not giving treatment to attack the cancer. We're giving treatment to allow the immune system to attack the cancer. So there's no plateau. It's going to keep on going and going as we get better immunotherapies. So this is lung cancer. Okay, a survival curve for lung cancer looking at this. Immunotherapy for people with what's called a PD-L1 positive, if they have a high amount of PD-L1 on the tumor, for immunotherapy versus chemotherapy. And going out a year and a half, you can see about half of people are still alive on chemotherapy. About 70% of people are still alive just taking immunotherapy, not even on chemotherapy. So this is now our current algorithm for lung cancer. Historically, it was always chemo, chemo, chemo. Now, less than half of people are starting off with chemotherapy. Why? Because 25% of people are now on targeted therapies. They just take pills. About 30% of people are just getting immunotherapy, okay? And that leaves less than half of the patients, 45%, who are actually starting off with chemotherapy. Now, the ultimate hope, okay, because the challenge is that most people with metastatic cancer, unfortunately, we tell them, unfortunately, this is not a curable disease. We're hoping to make this a chronic disease and to allow you good quality of life, but this is not something we can cure. But the holy grail would be in your lifetime to come up with something like this. This is a living immune therapy. If anybody heard of CAR T cells before, made the news over the last few years. So in acute leukemia, as well as diffuse large B-cell lymphoma, these cancers of the immune system, it was first reported, I remember, about 4 or 5 years ago, I think out of a small trial of like 10 people in Florida, okay? These are at a hospital where people were treated over and over again for acute leukemia and lymphoma and basically dying of their disease. They had run out of options. And they decided, well, if you have this police force in your body, instead of just trying what we do now with the other immunotherapies and just trying to let them see the cancer, why don't we take it out of the body, train the police force, and put the special forces back in your body? Okay, that's what CAR T cells does. So CAR T cells are living immune cells, T cells, where they take it out, they expose it to antigens called CD19 in a laboratory, and then they inject it back into you. And what they did was this. So majority of people, about 2/3 of people, will have a complete remission with this treatment for leukemia and diffuse large B-cell lymphoma, okay? 2 out of 3. The majority of people who get a complete remission, meaning no visible cancer, it appears now years later, which is a lifetime in acute leukemia and lymphoma, that they appear to be cured of their disease. Okay, now the challenge is that these companies charge about $400,000 for this treatment, but in a disease which you would be normally dead in months and to be able to be cured, it is truly remarkable. Now this is only what we have now in lymphoma and leukemia, but the hope is to now be able to use this kind of treatment in other kind of diseases. So in summary, we have made great advances in treating cancer. More than 2 out of 3 patients will be cured of their disease, and those who are not cured, we have a lot of hope now to have longevity for many years and to allow quality of life during that time. The goals of care are, again, both quantity and quality. Not always are they fighting each other. And the arsenal of attack can be chemo, endocrine therapy, targeted therapy, and immunotherapy. Now, this is my favorite cancer survivor, my wife. She was treated from age 6 to 9 for acute leukemia, so she had 3 years of chemotherapy and doing well. And this is our new cancer center, which will be open in December on campus. So we're all excited about that for our patients. So thank you very much.
Does anybody have questions for Dr. Lowe? There's a microphone coming. Right there.
Hi, thank you. That was great. A lot of hope. I know with AIDS, they've worked on making exactly what you're saying, a chronic illness. And even in multiple sclerosis, same thing. Is this kind of similar lines or, I mean, it's revolutionary when we've seen it happen.
I would say yes, of course, very different diseases, but I think like AIDS was thought of in the 1990s and into the early 2000s, where in the 1990s until, when Magic Johnson, I remember where I was when I heard Magic Johnson had AIDS, and I thought, good gosh, he's going to be dead in a couple of years. I mean, that's what the reality was back then. Magic Johnson is now alive in, 2019. I think similarly you could say that for the world of cancer. I think historically it was always chemo, chemo, chemo. How can we, instead of chemo every 3 weeks, let's make it every 2 weeks, or let's make it stronger, or let's add things to it. And it was very hard because people with metastatic cancer, all you're doing is adding chemotherapy, and at the same time it was very hard to have quality of life. And now with all these other treatments, it's looking at treating cancer in different ways. And it's very gratuitous because early in my career, none of this seemed possible. And now it's amazing. Every month there's a new drug approved for some disease which we thought that there wouldn't be good treatment for. So yes, it's very satisfying.
So even though they're different illnesses, there's some sharing or similarity to the way it's considered working towards chronic illness.
Right, right.
Thank you.
Yes. We have read and heard about the use of Avastin for breast cancer and some others. Can you speak about success rate in using Avastin in ovarian cancer?
Yeah, Avastin has been approved now for ovarian cancer for quite some time, many years. Okay, it actually shows better activity with using it with chemotherapy to make chemo work better, as well as you can use it alone, and it has some activity in ovarian cancer. The challenge is, and why I don't often use it in ovarian cancer, is people have often already had multiple surgeries in the abdomen, or even just the one surgery. It's quite an extensive surgery, and they have a lot of scar tissue in the abdomen. The main thing we worry about with Avastin is it can cause bleeding or clotting, and it can cause bowel perforations. So it doesn't happen very often, but it can happen more commonly in women with ovarian cancer. So I personally, if we have other options, I don't like to use much Avastin unless I'm running out of other options, because when patients have bowel perforations, it can be quite severe. Yeah.
How much of this technology would you devote to the Genome Project and that identified a lot of this stuff that you see? And also, I know that they're going forward in the genome and going after peptides and other things like that. How much is devoted to that actually made this possible?
Right. I think the Genome Project was looking back all the way back against the 1990s and 2000s, trying to sequence our DNA, which literally initially would take years on a single person to do. Now it can take days for a single person to actually type their entire genome if you wanted to. So that allowed finding of certain mutations, like the BRCA mutation, which was identified in the late 1990s. Okay, and given that we're able to identify with those mutations, what that means for women and whatnot. But I think a different related is not the Genome Project, but looking at what genes are mutated in cancer. The future of cancer will not be, well, what are we doing for breast cancer, or what are we doing for colon cancer as far as treatments for those diseases. The treatments are going to be is, well, what mutations does that cancer have, and what drug is going to target those mutations. So there are now 2 drugs. One of them was recently approved last year called an NTRK inhibitor, which is a drug approved not based on cancer diagnosis. It could be any cancer, but if it has the mutation, you can use that drug, meaning it's active in basically any cancer that has that mutation. So the future of oncology is going to be take the cancer, send it to a lab, figure out what mutations you have, and it's going to give you a list of targeted drugs that you have available. Yeah.
Can you tell me where they stand as far as immunotherapy for metastatic breast cancer?
Yeah, it's now approved for triple-negative breast cancer, if it's what's called PD-L1 positive. For immunotherapy has not been successful in hormone-positive breast cancer, okay, at least not yet. But as of about 2 or 3 months ago, an immunotherapy called atezolizumab, which is a sister drug to these other drugs I was mentioning, got approved with chemotherapy for triple-negative breast cancer, one of the most aggressive breast cancers we can see. Only if it has that badge. If it has that badge, yes, we use it now standardly. And it just recently got approved for that. Yeah. Triple negative, so hormone negative, meaning estrogen and progesterone negative, and HER2 negative. Yeah.
When your chart went up, looking at the different survival rates and improvements, it was pretty grim for pancreatic cancer. Can you
Yeah.
talk about that a bit?
Yeah, pancreatic cancer, I mean, the historic survival was about 5 or 6%. Okay, so of all patients diagnosed with pancreatic cancer, about 1 out of 20 would be cured. Now that's slowly increasing up. Unfortunately, the advances mainly have been made in the metastatic setting, where instead of living 6 months, we're seeing patients live now years. But as far as curing, which is really important, you know, the cure rates have maybe edged up from about 5%, getting closer to about 15% now, but it's still a way far off way to go. Yeah, we're getting much better for pancreatic, unfortunately, at the metastatic setting than we are the curative setting.
Okay, I have a couple of questions. In regards to prostate cancer, there's the medication, the Lupron,
Mm-hmm.
and I'm saying because my husband was taking Lupron, and then the urologist says, no more Lupron. It's the Exanti. So
Yeah.
Exanti.
Mm-hmm.
So he's taking
Extandi,
that.
yeah.
Exanti. Okay. So he's taking that. So that's one. You know what? I mean, is it supposed to be combined? Does it
Yeah,
really eliminate?
usually we continue both. So the idea of prostate cancer, you're taking away its food, right? So Lupron actually is chemical castration. It takes away testosterone being made by the testicles. And then Xtandi blocks testosterone from binding to cancer.
Okay.
So typically, Xtandi is not taken alone. Typically, we still lower testosterone at the same time, block testosterone. So most men, unless they can't tolerate Lupron, most men will stay on Lupron and also take Xtandi, usually, unless there are extenuating reasons why not to.
Okay, and another one is that he was recently implanted with an infusion system for pain management, and also had radiation, target radiation, both on his knee and his neck. They're saying there's a possibility that he can, because of I guess the bones are very fragile, and they were suggesting putting a plate on his knee in order to support, to bear weight. Now his neck, apparently there's no recourse other than wearing a brace, because the cancer is both on the top of, I think, C4 or whatever of the disc, and can't be repaired internally. My question is, now they put the infusion system in, and then they target. So he had 5 series of radiation target. Was that supposed to eliminate his pain, and the infusion system comes later? My concern is that if the morphine is being distributed in slow dosages, is he being over-medicated? I mean, that's...
Yeah, that's a hard answer. I mean, the idea of radiation is where you give radiation, yes, you could eradicate the cancer at that site, but in the bone, even if you get rid of the cancer at the site, the damages have been done. So you have like the analogy I use is a concrete wall, right? That's your spine. And then there's been damage, it's crumbling, okay? And you can use radiation to get rid of what's causing the crumbling, but then you're left with this crumbling wall where there's a lot of sharp edges. And that's what causes the pain as it pushes down on itself. So radiation works very well to treat the cancer and get rid of the cancer, but you're still left with the damage that's already been done. So then you're dealing with a pain pump, which you're just treating pain. So as far as how much, too little, it's subjective for everybody.
Okay, and then the last question is, how is that immunotherapy? Does it have anything to do with prostate cancer? Can that?
Not yet. Not yet. It has not been shown to be active for prostate cancer yet. Yeah.
Hi, 2 questions, or 2 topics. One, routine screening for lung cancer. I'm not aware that there is any, and I'm wondering kind of where we are with that. And the second one is are there what kind of targeted therapies for lung cancer are there right now?
Yeah, lung cancer, yes, is EGFR, ALK, ROS1, BRAF, NTRK, multiple targeted therapies. Immunotherapies like we listed, yes, there's a ton of treatments now for lung cancer if you have the right kind. But as far as I'm sorry, what was your first question again? Oh, the screening. Oh, so screening, historically, doctors would do chest x-rays, which did nothing. They did multiple studies looking at chest x-rays, never showed to improve survival. Now there are 2 trials, national trials, which showed improvement in survival with CT scan screening, which you could actually order, you can actually call in yourself if you're a heavy smoker, smoke more than a pack a day for more than 15 to 30 years, and then you actually qualify what's called low-dose CT screening, which Torrance offers. It's been shown to reduce the risk of dying of cancer by 20%, although the risk is still low of getting lung cancer. It is available and actually covered by most insurances, and even if it's not, it's a very low cost.
So I smoked less than 15 years, but almost 30 years ago.
Yeah, you would not qualify because your risk would be so low that you would be really no medical reason to do a CT scan on you.
Okay, I think that's,
This is
one more question, sorry.
I've lost 2 family members who are in-laws to pancreatic cancer, and I'm wondering if you could comment a little bit about what the challenges are at this point. Is it inability to test and diagnose? Is it misdiagnosis? Is it a variety of things? What's going on with the pancreatic cancer?
That's the problem with pancreatic cancer is it's very difficult to diagnose unless someone has symptoms, and by the time someone has symptoms, it usually has already spread to the liver. There's no good screening tests for pancreatic cancer. It often starts with very vague symptoms until someone starts to have a lot more symptoms with weight loss and pain and digestive issues. But for you personally, if you have 2 family members that have had pancreatic cancer, and I presume have passed from pancreatic cancer, you would qualify for genetic testing, especially for the BRCA gene. Certain genes, including the BRCA gene and other genes, that if someone has died in your family from pancreatic cancer, we can't test them. So nowadays, anybody with pancreatic cancer, we test for genetic mutations for a possible BRCA mutation. So if I were you, I would, we have a genetic counselor here, and you can actually, be referred and talk to her, and she can test you.
Thank you.
Yeah. Oh, okay, then it's okay. Yeah, but their family can be tested. Yeah.
Thank you very much, Dr. Lowe. What I come away with from that is hope, because there's a lot of new things happening, not only in early disease, but making metastatic disease chronic disease. We'd like to continue and bring up Dr. Eve Makoff. Dr. Makoff is board certified in internal medicine and hospice and palliative care, and currently practices palliative medicine at Torrance Memorial. Previously to joining Torrance, Dr. Makoff served as the Assistant Director of the Supportive Care Oncology at the Samuel Ocean Comprehensive Cancer Institute at Cedars-Sinai in Los Angeles, where she helped integrate palliative care into the cancer center. Prior to that post, Dr. Makoff served as the lead hospitalist at Cedars-Sinai, where she served as Director of Community Relations and helped to grow that program. It was while practicing as a hospitalist and caring for seriously ill patients that Dr. Makoff became interested in the field of palliative care. Prior to practicing hospital medicine, Dr. Makoff worked in private practice as a nephrologist. Dr. Makoff received an English undergraduate degree and master's degree in English and comparative literature from Columbia University. She also completed Columbia's post-baccalaureate pre-medical program and went on to receive her medical degree from Brown University Medical School. She completed her internship, residency, and a nephrology fellowship at Cedars-Sinai Medical Center. So please help me welcome Dr. Makoff.
Hello. I didn't know we were going to talk about my undergraduate degree. Really happy to be here. So this quote, "The secret of the care of the patient is in caring for the patient," is a quote from Dr. Francis Peabody from 1927. I'm a palliative care physician, but before we talk about palliative care, I'd like to pause. Let's take us all through a breathing exercise, for me to calm myself down and for you to relax. I know you just had stretching, so she took my fire a little bit, but let's take a moment to scan through your body, feel places of tension, Notice what parts of you want to relax, to let go a little. Take a full and deep in-breath. Expand your chest and your lungs. Take a very slow out breath, feeling the sensation of the breath and its release. And again, deep breath in and slow breath out. Now let your breath resume in its natural rhythm, opening to your senses, feeling your breath in the foreground and relaxing with the background of sounds, feeling, and life. That was adapted from Tara Brach. She's a psychologist and she's an expert in mindfulness and meditation. I highly recommend her book. It's also an audiobook and it's amazing. So here we are. I'm going to teach you about palliative care. Have you heard of it? Anybody want to say what you think it means? I have some patients out there, so you guys know. Okay. So palliative care is really about helping people to feel that they're not alone. This picture describes what I think most providers hope that our patients feel when they leave our offices. As Michael Carducci, a doctor at Johns Hopkins University School of Medicine, describes, in my practice, I strive to note the detail in my patients' lives and in their illness to gain greater insight into my interactions with them and their families. It's in being cognizant that every patient is unique and beautiful in their own right, and that personalized medicine isn't in the drugs or treatments we recommend, but in the manner that we approach each patient as to where they are and what they need. Palliative care is first and foremost a specialty that focuses on communication, because we know that it is in the talking and in the listening that we find out where and how you are suffering. So what issues do we address? Palliative care helps to provide the best possible quality of life for patients and their families. We help patients and families manage the pain, symptoms, and stress of serious illness. We help provide an extra layer of support for families of patients with serious illness, and it's appropriate at any stage and at any age during a serious illness, and it can be provided along with curative treatment. More specifically, we address physical symptoms, pain, fatigue, loss of appetite, nausea, vomiting, shortness of breath. We address emotional needs. We manage or we refer to help with anxiety or depression. We address spiritual needs. We help people find and explore their beliefs and values so that they can find a sense of peace or acceptance with where they are. We address caregiver needs. We help the whole family unit to cope and provide resources and support. We also address practical needs. We discuss goals of your care. We help with advanced directive completion, and we help facilitate communication among family members, patients, and the medical team. We pretty much try to help with any requests that you may have. For example, I witnessed a wedding in a hospital chapel arranged by a palliative team because a patient was hospitalized and wanted to get married just then. Palliative care is not end-of-life care. Studies show that 7 in 10 Americans are not at all knowledgeable about what palliative care is, and even many medical providers associate palliative care exclusively with end-of-life care. But when palliative care was explained to the same people, 95% of respondents agree that it's important for patients with serious illness and their families to be educated about palliative care. About 92% said that they would be likely to consider palliative care for their loved ones if they had a serious illness after learning about what we do. Also, palliative care addresses the issues that patients with serious illness list as their most significant concerns. These concerns, according to the Center to Advance Palliative Care, include that doctors might not provide all of the treatment options or choices available to patients. Doctors might not talk and share information with each other. Doctors might not choose the best treatment option for a seriously ill patient's medical condition. Patients with serious illness and their families sometimes leave a doctor's office or hospital feeling unsure about what they're supposed to do when they get home. Patients with serious illness and their families do not have enough control over their treatment options. Patients with serious illness are concerned that some doctors don't spend enough time talking with and listening to their patients and their families. These are the issues that we help to address. The cornerstone of palliative care is in the listening to the needs of the patients and families and finding ways to address any of your needs. In palliative care, we help patients keep up with their losses as they roll in. This is according to B.J. Miller, who's an expert in communication in palliative care. He has some great TED Talks if you want to check them out. When dealing with metastatic cancer, some of these losses include, among other things, the loss of health, as you know it, the loss of what you thought retirement would look like, and the loss of autonomy or dignity at times while going through cancer and its treatment. Dr. Miller describes palliative clinicians as reflective advocates who focus on how you find comfort and live well with your disease. In the words of Dorothy Hunt, peace is this moment without judgment. That is all. This moment in the heart space where everything that is welcome. Our goal is that you feel supported with your physical and emotional needs addressed throughout the trajectory of your disease. We may refer in palliative care to the tenets of mindfulness to help patients make sense and find peace in the here and now, hence the pause at the beginning of this talk. And that's all. Questions?
Yeah, I have a question.
Sure.
It seems that my husband's stage 4 cancer, prostate cancer, and one of my biggest concerns now, along with his health and finding the right medication and treatment, is him coping with the situation. A lot of the concerns that you had mentioned. So how do you get a handle on this, and how do you direct your care team to focus on that aspect, which seems to be overlooked or almost ignored?
Well, it's part of the reason that there are palliative care specialists. I mean, often the oncology team and the rest of the team that you're working with, whether they're surgeons or whomever else, do address things like pain and other symptoms, but sometimes our role is to put it all together and focus on all of the symptoms, including emotional symptoms and coping. So if you have the ability to get your husband to see a palliative specialist, you may ask your primary oncologist or primary care provider. They might be able to refer you. Okay.
So is palliative care also available for people with acute serious medical problems?
Yes, anything that's serious. I mean, it's not all about people who have a chronic disease or a terminal disease. Anytime someone goes through something that's sudden or traumatic in the hospital, we have palliative providers as well. So yeah, I mean, sometimes it's entirely to help a family be supported during the course of an acute illness, for sure. It's just usually people who have something serious going on.
I have a question.
Yes.
Can you talk about how palliative care works with symptom management? Can you expand on that a bit?
Sure. Well, when I see patients, I screen them regularly for a whole host of symptoms, including anxiety and depression, but they do scales looking at pain and shortness of breath and nausea and things like that. But I basically go through every potential symptom that people could have, and symptoms related to cancer itself and also symptoms related to therapy. Since I've been working with oncologists for about 7 years, I'm familiar with a lot, not all, chemo and all of the side effects of targeted or immune therapy or chemotherapy, but I usually, if I don't know, I will find out, and I can help with symptoms related to the treatments as well as the cancer itself.
I'm thinking back to people in my life who've died from cancer and being involved with their care. Where are you / the establishment, if you will, now regarding things like morphine and morphine drips versus, the Canna products, that type of thing, and how involved is Torrance Memorial's hospice department and I guess palliative care department, how involved are you in educating your patients and their families on what is available to them with the changes in our state law in that matter?
So are you talking about end-of-life care and hospice? Are you talking about options at end of life? Or are you talking about pain management with regards to morphine?
Palliative care for anybody who would I guess qualify, if that's the correct word?
Yeah,
for
anybody who has, even some patients who don't have an advanced cancer diagnosis but are struggling in whatever way with symptoms or with emotional issues, I will see. But if somebody happens to have a disease that's progressive, I also work with them as things get harder on their pain management regimen and start them on new medications. And yes, if they're near end of life, I will refer them to hospice. We do have a hospice here at Torrance, but we know that there are other hospices available. But are you talking about the death with dignity law? Is that? Yeah. So that's a law in California as of, I think, 2015 or 2016. And that's something that is provider specific. Palliative providers don't usually prescribe the medication, but we will help either a primary doctor, an oncologist, whoever is willing to write the prescription. Institutions and providers are allowed to opt out. So you have to, if somebody decides they want to go that path, and most people don't take that medication. About a third of the people who obtain it actually take it. It's just if people feel like they want to know that they have that option, they sometimes will go through the process so that they just have it in their back pocket. You know, it's not something that most people feel they need to do. But Torrance has not opted out, but it's provider specific whether somebody will go down that path with a patient. And then hospice, we don't use just morphine drips anymore in hospice. We treat symptoms as they arise, and some people go on hospice and live longer than they would have lived had they continued with chemotherapy if they're very weak. And the goal is to optimize your quality of life.
All right, thank you very much, Dr.
Thank you.
Makoff. I've been in oncology, about 40 years, and it's just a great. We didn't have this when I started. We didn't have these options, and we didn't have these resources. So I'm just really pleased that in our community we have we have access to palliative care resources, because it was an all or nothing for a long time, and now there's a lot of support that's available. So with that, I'd like to introduce Nancy Lomibao. Nancy has been licensed as a marriage and family therapist since 2000. She earned a Master of Science degree from California State University, Dominguez Hills in marriage, family, and child counseling. She's currently a doctoral student enrolled at California Southern University, working towards her doctorate degree in clinical psychology. That's a lot of work. Good job. Nancy has worked at the Cancer Support Community Redondo Beach since 2014 and is currently the program director and chief clinical director. She oversees the programs that support cancer patients and their loved ones and provides psychosocial support as well. This includes group and individual counseling, mind-body classes, and educational workshops. Nancy has an extensive background working with victims of domestic violence and abused children in both residential and non-residential settings. She is trained through the Department of Mental Health to provide evidence-based practices for treatment of children and adults. Nancy has lived in the South Bay her entire life. Impressive. She's married with 2 children, and she enjoys teaching art, making jewelry, and shopping. Well, okay. With that, I'd like to introduce Nancy Lomibao, who's going to talk about emotional and social support. Thank you.
Good evening, everybody. Hopefully you have noticed that what we're trying to do tonight is make a progression between moving from addressing the needs of physical health on through emotional help and health. And Dr. Makoff, when she discussed palliative care, spoke a little bit in terms of these emotional support needs. So that's my topic tonight, social and emotional support for individuals with metastatic cancer. What I wanted to share with you just on a personal note is, for me, it is personal. This, for me, at Cancer Support Community has been the year that we've introduced our metastatic, we call it Living Well with Metastatic Cancer. And I'm motivated with my own history. When I was 16, my dad was diagnosed with prostate cancer, and it metastasized, and at 22, I didn't have a father anymore. Within the last 3 years, actually 3 years ago, I lost my sister, my brother-in-law, and my grandma to metastatic disease. And of course, last year, I lost a very dear friend to metastatic breast cancer. So although that might sound depressing, what keeps me motivated is all of you guys. And I want to share that with you, that background, so that you understand this is something that's not just my job, it's something I'm personally motivated to address. And I think at Cancer Support Community, we were doing a really great job at addressing the needs of cancer patients, but overlooking the metastatic piece, and whether it was too scary to look at, or looking at outcomes that were very negative, we decided, you know what, we can take a look at this and really focus on the positives of living with metastatic cancer. You know, we're all here today, and that's where we want to move forward and live well. So with a metastatic diagnosis, there is that emotional overwhelm, that living with uncertainty. And that unpredictability can be so incredibly difficult, disheartening, just feeling like you're lost, not knowing what to do. So that emotional response that comes with an initial diagnosis, that's normal and that's to be expected. And it's really important that we look at the differences between uncertainty, stress, distress, and then when to reach out for help. So you might need some extra help with dealing with the fear and the worry and the anger and the despair that can come up with this kind of diagnosis. So uncertainty, when we use that word, it refers to the doubt, the suspicion, that lack of sureness about what the future holds. And it can also be that unfamiliarity or the lack of knowledge about an outcome or result in terms of what's going to happen next. So questions that often comes up are things like, what happens now? How do I make a treatment decision? What will the treatment be like? How will I feel? Goes on and on. Will my cancer come back? What if the treatment doesn't work? Am I dying? And there's a certain ripple effect to a metastatic cancer diagnosis. It doesn't just impact and affect the individual with cancer. It affects children and spouses and friends, and impacts other areas of your life. So when that uncertainty becomes anxiety, it's really what's a natural temporary adjustment and when do I need it to reach out for professional help? So symptoms of anxiety: excessive worrying, feeling agitated, restlessness, fatigue, difficulty concentrating, irritability, tense muscles, trouble falling or staying asleep, panic attacks, avoiding social situations, irrational fears. Those are 11 of the symptoms of anxiety. This is the anxiety iceberg. And what you'll see is up on top of the iceberg, there's that behavior, the anger, the defiance, sleep issues, avoidance. And underneath, you'll see there are all those feelings of embarrassed, ashamed, disgusted, overwhelmed, depressed, stuck, grief, lonely. When we look at anxiety, a lot of times there are so many emotions and feelings underneath that are triggering that anxiety. And we see a lot of people who, with a cancer diagnosis, it re-triggers other times in their life when they have felt these same similar feelings. So if they're feeling scared and outraged, that might tap into something that happened to them earlier, an earlier trauma of perhaps abuse or a rape or other really upsetting things that have occurred in their life. So when we're treating cancer patients, it's very common for other things to come up, other traumas to be discussed. And this is when uncertainty becomes depression. So how many of you have been up late at night and you hear the commercials come on TV and they say, you know, ask yourself these questions. Am I having crying spells that seem to come out of nowhere that I cannot control? And for some of us, as we hear these symptoms of depression, it's like that the teacher in Charlie Brown, wah, 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 wah. But what we know is that for something that resonates with us, we tune into it. And when it doesn't resonate with us, we can tune it out. And of course, late at night, that's when all of the antidepressant and all of the pain management pharmaceutical commercials come on, because that's when people who are depressed, who are anxious, who can't sleep, who are experiencing pain are all wide awake at 3 a.m., right? But it is important because there are people probably in this room tonight that are experiencing these symptoms of depression. So I do want to just read through these with a serious tone, because if they do resonate with you, it might be the impetus for you to reach out and get some additional help. So the crying spells, the losing interest in things that you used to find pleasurable, looking forward to events if you've stopped being brought joy by these types of events and occasions. Are you too tired to participate in the things that you're passionate about? Have you lost interest in most things? Are you having trouble sleeping, oversleeping? What about your appetite? Are you overeating, or have you just lost your appetite altogether? Concentration is very central with depression, having a difficult time concentrating, making decisions, remembering, feeling irritable, grouchy, guilty, or helpless. And have I stopped reaching out to family and friends? So if you answered yes to 4 or more of those questions, particularly if it's lasted for a week or more, it could be that you are experiencing symptoms of depression. And that's where you would want to get assessed by a professional and find out how you can target that and treat that. It's important to remember that you don't have to face this diagnosis alone, and that you deserve to be helped and supported. Of course, down here, this is the obligatory statement. If you're feeling suicidal, please seek help immediately. Call 911 crisis line or emergency room. So there should be no shame in discussing these. In fact, Dr. Makoff and Dr. Lowe talked about bring these up. These are things your oncologists, the palliative care specialists can talk with you about. Talk to your healthcare professionals, and there's a number of different interventions that can be used. So support groups are wonderful. There's a lot of research that shows support groups can help decrease the symptoms of anxiety and depression. There's individual, couples, family therapy. A lot of times, as I say, it impacts, not just the cancer patient, but communication difficulties come up, issues regarding how do I tell my adult children, how do I tell my young children, how do we discuss this and get through this as a family? That comes up quite a bit. There's also pharmacological interventions such as antidepressants or anti-anxiety medications. and integrative approaches such as acupuncture, meditation, other things like that. This is just a slide here talking about finding a counselor and a therapist. A lot of times your oncology practice is making a number of referrals, and so they may have lists of people who specialize in cancer, chronic illness, end-of-life issues, and so you want to be able to find someone who has experience and a background in that. Psychology Today, the website, it's a wonderful resource that has a number of therapists listed. What's particularly great about that is that there's filters where you can put in your insurance company, you can put in your specialty that you're looking for, you can put in the zip code of where you want to find a therapist, and then what pops up are profiles and photos of potential therapists. So you can read a little bit about who you might be going to. Seeking opinions from cancer support group members and other friends, people who've been there, done that. They may have someone that they're using that would be a great referral for you. And then once you've chosen someone, we always encourage, go a few times first before you decide whether or not it's a good fit. It can be very scary. You may not like your first session, but we encourage you, try it 3 times. And we use this same philosophy at Cancer Support with the support groups. You might just happen to come on a time where it just doesn't go right, but come back the next time, come back one more time before you decide whether this is for you or not. So support groups, they help to reduce isolation and aloneness, those feelings of loss of control and helplessness. And there's a number of in-person support groups. Torrance Memorial has some wonderful support groups. Cancer Support does, but there's also online support as well. And there's a number of Facebook groups that are specific to different types of cancer, to different kinds of medications, even different cancer-related procedures that I know have been supportive and helpful to some of the cancer patients that I see. So the benefits of support groups is that they help to normalize and they manage the management of the depression and anxiety. They give opportunities to talk about body image, intimacy, relationship challenges, all those things that start to change with a cancer diagnosis. Sharing information and education. It's reducing isolation, it's getting you out, it's connecting you with people. It provides that opportunity to talk about those fears and concerns that either you may not want to burden your friends and family members with, but being able to talk about it with someone who understands, who knows, and is there and has been there. And of course, it's also a place to celebrate good news, finding hope and providing encouragement, and finding out about resources. It's such a wonderful exchange of resources and referrals. This is an example of the flyer that's in front of you, the Living Well with Metastatic Cancer. We offer this group the second Monday of every month. As I mentioned before, it's a brand new group that started in January of this year, and it's continuing to grow. But this is also my opportunity and my plug to say, please check out all of the flyers that are at Torrance Memorial and Cancer Support. There's all other kinds of wonderful cancer-specific support groups. So this is some of the integrative tools and techniques for managing the difficult emotions. If you can find a class or a place to go that offers some kind of exercise and movement, research shows that that is huge in being able to kind of come out of your shell, come out of your depression, move through some of that anxiety. Course, yoga and other mind-body practices, deep breathing techniques. In that, there's some wonderful apps. There's the Calm app on your telephone, on your cell phone. There's another one called Insight Timer with a number of meditations and breathing exercises. And then the other great resource is YouTube. Being able just to type in guided visualization for healing, or guided meditation for sleep. Those are all wonderful resources if you can't get yourself to a mind-body class or a meditation class. Timed worry is a cognitive behavioral strategy where you set a timer and say, okay, I'm going to stress and obsess about whatever that is going on for 10 minutes, and then I'm going to let that go and move on with my day. Nature, connecting with nature, getting out, just changing the atmosphere, we live in this beautiful community, a beach community, of being able to walk on the beach. We've got some great places with lots of trees and nature to connect to. Laughter is another wonderful technique for managing depression and anxiety. And so at Cancer Support Community, we always have free tickets available for the Comedy and Magic Club. And every other month, we have comedians who come and do a presentation called Love and Laughter. And it's just a night to eat and laugh. Some more information about guided imagery, I spoke to that. Spirituality, so being able to connect in some spiritual way, whether it's through a church or synagogue, but also with other people who share your same thoughts and ideas about spirituality. And journaling or expressive arts. I love arts and crafts, and I think that it's something that can take your mind off what's going on. It's something that can help you feel like you create, and it's something you can look forward to. Of course, the focus on nutrition, sleep, and exercise is huge. That can be a presentation all by itself, so I'm not going to go too much into that, but I think it's something worth evaluating, and it's something also being able to look and see what is out there, to address those types of things. So I know at Cancer Support and as well as Torrance Memorial, we're very focused on offering, we have a monthly cooking class with a focus on nutrition. I know Torrance does now too, monthly, correct? And we have different therapists who come out and talk about sleeping techniques. And of course, every day we have some form of exercise and yoga, as does Torrance Memorial. Mindfulness-based stress reduction, massage, sound therapy meditations. There's a number of, whether it's Tibetan singing bowls with gongs, there's crystal alchemy bowls, instruments that can be played for relaxation, for meditation, to help take your mind off of things and move through that depression and anxiety. And Reiki is another sort of alternative additional support. Does anyone know who that is? That is Harley. That is my pet therapy dog that comes to Cancer Support Community with me, and this is one of my favorite ways of addressing and reducing anxiety and depression, being able to pet and love and have a purpose with an animal. So he comes in and goes to different groups and visits. So with that, I'm going to end and take any questions.
Thank you, Nancy. Does anybody have any questions for Nancy? She's around and accessible. Oh, okay.
One of the early slides said chandeliering. Was that the word? What does it mean?
Chandeliering.
Where it had all those words. Above the iceberg, I think it was above it. Chandeliering.
Oh, the this one here.
Oh, yeah. Under Defiance.
I have no idea. I did not create that slide. Let's make something up. What would chandeliering, a behavior, hanging from the chandelier and feeling like you're swinging back and forth with no control? Yes.
one of the things that, try to navigate through all this, and part of it is the psychological effect on stage 4. And in seeking professional help, can you narrow down the who, what, and where to find this help?
Yeah, so she's asking, can you narrow down the who, what, when, and where of seeking help? I would say from my perspective, if you're able to get some resources either through your oncology practices, cancer support here at Torrance Memorial, that would be ideal because they know that the private practitioners who work specifically with cancer and grief issues. I know at Cancer Support we have a list of psychotherapists and psychiatrists in the area that work specifically in this area. But the other one too, I really love the Psychology Today website. I look it up all the time because of the filter system where you can type in the different zip codes and also be able to filter by insurance companies and be able to filter by topic or skill area of the therapists. And you're always welcome to call Cancer Support Community. Like I said, we have a list. We can email it to you. If you come in, we're happy to hand it to you. And you'll be able to see on the list, there's things that are created, specifically where the therapist can write down their true specialties.
I have a question about biofeedback. I don't hear too much about it, but I know it is around. My niece uses it, and she was born with some disabilities and things. So, and it's worked for her, but I don't hear too much about it.
Biofeedback, actually, I do some biofeedback in my private practice. I use the Othner method. It's one of those things that it's sort of actually decreasing in terms of interest level, that because it takes time, they recommend people go in for, starting off with say 24 sessions, 48 sessions. It's a lot of time and energy, but it is something that can help with, they've used it for cognitive difficulties, ADHD. I don't see it used as much in depression and anxiety, and there's techniques and also theories and modalities that work a lot better with those. So I see cognitive behavioral therapy as probably one of the best modes to treat anxiety and depression. Any other questions? Thank you.
Thank you, Nancy. When anybody saw that slide before, did I just move that? It did remind me of the Titanic. I don't know if anybody else went there, but it's really reassuring to know from when I'm looking at that it doesn't have to be the Titanic. We can survive and will survive that iceberg that appears in our path. I'd like to have us all thank our speakers tonight, Judy Schneider, Dr. Thomas Lowe, Dr. Eve Makoff, and soon to be Dr. Nancy Lomibao. I certainly learned a lot. It was an evening that I think is very positive and really reinforces the living and thriving with metastatic cancer. We went from hearing how cancer can be a chronic disease and all of the strides that have been made to understanding what resources and tools are available in terms of understanding how we manage and how we cope with a chronic illness, questions that we have about our mortality in a lot of ways, depression and anxiety. I just would like to remind everybody that we heard a lot about cancer support community and Torrance Memorial, but all of the provider organizations in our community have different access to different resources. So it's not just those two. Kaiser, depending on where you're getting your care provided, Kaiser, Healthcare Partners, Harbor, UCLA, we all have different resources available. So the big onus falls on the individual to ask. And ask somebody, okay, I need this, I don't understand how to do that, I have a question about that, and ask the provider, and that will open the door to a lot of different resources. You know where they're located, we've been talking about them all night, but there are resources all over the South Bay. And I encourage you, if you have a question or you have a concern, to really make sure that you are advocating for yourself or your loved one and seeking them out. With that, I'd like to end tonight. Please, just reminding everybody to fill out their evaluation form. As I said at the beginning, that is how we hear from our community as to what you want to hear about, what you want to learn about next. Look for us. If you're not on our mailing list, make sure you sign the bottom of the evaluation form legibly, please. And I will either email you or we'll email you or send you our flyer for our August program. So if you're on our mailing list, you'll automatically get it. If you're not, and you'd like to be on our mailing list, we don't send anything but information about our programs. We don't advertise anything. So you're just getting information about the upcoming programs. And like I said, we do them twice a year, in May and in August. So with that, hopefully we'll see everybody in August. Thank you for coming tonight.